All right. Good afternoon, everyone. Welcome to our webinar today called Adverse Childhood Experiences in Arizona and Their Associated Costs. My name is Kavita Bernstein, and I serve the Arizona ACEs Consortium as the chair of our board. We're delighted to see so many of you spending your lunch hour with us today. In fact, we have just shy of 600 registrants for this webinar. It's the most that ASU Morrison Institute and our consortium has seen. This definitely demonstrates what a critical topic this is to you, us, and our state. So today, we are going to hear from 4 experts in Arizona about a first one-of-its-kind report that was completed by the ASU Morrison Institute. We want to thank the team at the Morrison Institute for analyzing the data and publishing the report. And we also really want to thank the Arizona Community Foundation for its generous funding to ASU Morrison Institute that allowed the analysis and the report to be completed. So a couple of housekeeping items. Again, attendees are all muted with video off. Please feel free to use the Q&A box to drop any questions that you might have for the panelists. We will have time towards the end of the webinar to address any questions to the panelists themselves. So with that, let's go ahead and meet our panelists. So panelists, please feel free to turn on your video. I'm going to wait till I see everyone. All right, great. Great to see you all. How about Dr. Rodriguez? Would you like to introduce yourself real quick?
Hello, good afternoon. My name is Luana Rodriguez. I'm a certified nurse midwife who serves Native women. I'm also a certified clinical trauma professional and a women's health advocate.
Great to have you here, Dr. Rodriguez. Sandi?
Good afternoon, everyone. I am Sandi Cimino. I am a member of the ACE Consortium, chair of the training work group. I am also a certified Strengthening Families Protective Factor trainer, as well as a certified ACE trainer, certified trauma support specialist, and happy to be here today.
Great, thank you so much, Sandi. Dr. Shaptak?
Hi, thank you for inviting me to be this amazing panel and discussion. I vividly remember the day I first came across the topic of adverse childhood experiences, and that day changed my own personal life, the way I practice pediatrics, and ultimately my career path. I used to work at a private clinic called All About Kids Pediatrics, started in 1998, and practiced there until September of 2020 when I closed the practice and joined Phoenix Children's full-time as a clinical pediatrician and then medical director of the Adverse Childhood Experience program called the Center for Resilience and Wellbeing.
Great to have you here, Dr. Shaptak. And Erica, would you like to introduce yourself?
Yeah, hi, my name is Erica Quintana, and I'm a senior policy analyst at the Morrison Institute for Public Policy, and I helped work on this cost of adverse childhood experiences report.
Great, thank you so much, Erica. So with that, I'm actually going to hand things back to Erica, and she's going to walk us through some of the findings, and then we'll come back to our panelist questions.
Yes, 1 second. Let me go ahead and load the presentation. Working with 3 screens here today. Okay, and Kavita, can you just let me know, can you see the presentation okay?
Yep.
Okay, great. So thank you everyone for being with us today. I'm here to share some of the results from the recent project. This was part of the Spotlight on Arizona's Kids project that was made possible by the Arizona Community Foundation. And the purpose of this study was to determine the associations between adverse childhood experiences in Arizona, health outcomes later in life, and the cost of these health outcomes. So adverse childhood experiences, or ACEs, which most of you probably know, are potentially traumatic events that occur in childhood. So this slide shows the ACEs that were assessed in the 1998 study from California that surveyed over 17,000 adults. The study asked adults about their experiences as children and their health later in life. and the study has a few key findings that have since been replicated. So from the study and subsequent studies, first, we know that ACEs are common, and nationally, about 61% of adults have experienced at least one ACE. Second, studies found that the more ACEs a person experienced, the more likely they were to have a chronic health condition later in life. So some of the chronic health conditions that have been associated with ACE exposure are listed here. And for this analysis, we were interested in focusing on the diseases that are among the leading causes of death in Arizona. But besides the diseases listed here, other studies have associated ACEs with cancer, depression, obesity, binge drinking, and substance abuse. In fact, and as a person's score increases, ACE score increases, so does the likelihood that the person will experience negative health outcomes later in life. That has been referred to as the dose-response relationship. And in the original ACE study, individuals who reported experiencing 4 or more ACEs were twice as likely to have chronic health conditions like heart disease, cancer, chronic bronchitis, COPD, and diabetes. So there have been a few other states that have conducted similar analyses, and I just briefly wanted to share with you what they found. So you can see from the slide that the other states, Alaska, Tennessee, and California, all looked at different diseases, and they used different methods for calculating costs. You can also see that those costs vary wildly from $800 million all the way up to $10.5 billion. And part of that is just because there's a lot of people in California. But one big difference between the other states' analyses and our analysis was that we did not include smoking in our cost estimate. And there's a couple of reasons for that. First, we were using access data, Arizona Healthcare Cost Containment System, and it becomes a little tricky to try to determine which Medicaid claims are specifically related to smoking. And then also, we didn't include smoking because there's a strong correlation between smoking and the other diseases that we did include, like stroke and COPD bronchitis. So our approach to estimating costs was very conservative, and that allows us to confidently say that the cost of ACEs in Arizona is likely much higher than what we saw in the analysis. So this information that you see here comes from the Behavioral Risk Factor Surveillance System. And that's a survey that is a partnership between federal and state governments. It's conducted every year. And the purpose is to collect data and inform public health. So from what you see, Arizona tracks pretty closely with the national trends in terms of how many ACEs adults have experienced. And you can see the prevalence of different numbers of ACEs here. So you can see that about 30% of adults have experienced 3 or more ACEs in Arizona. So data on ACEs are collected every 2 years in Arizona, and that started in 2014. And by combining the data across the years, we were able to determine attributable risk. Then by using a statistical model called the multinomial probit regression, we were able to determine the proportion of disease cases that are potentially attributable to ACEs for different groups. The model does that by predicting the most likely categorical outcome, like a disease, that a predictor variable, like ethnicity, sex, and exposure to ACEs, is associated with. So initially, we were interested in identifying attributable risk for different demographic groups like sex and ethnicity, but in many cases, there were too few people belonging to different categories to determine associations, or the associations were not significant. So let me just give you a little example of how that could happen. So in 2014, only 40% of the survey respondents were male. In 2016, 41% of respondents were male, and in 2018, that was 44%. So what that means is that each male respondent's answer had to be weighted higher to make it reflect the Arizona population split of male-female. Most of the time, weighting like that doesn't cause many problems. But in this case, it might have been a situation where there were too few responses for the model to estimate a relationship. And there's always other explanations for inconsistencies in self-reported data. For example, maybe people are less willing to share about their childhood experiences or their current health problems with a stranger who's conducting a survey. The truth is we don't really know why we couldn't estimate for males or specific ethnicities, but perhaps we can in the future with more data. But with the data that we did have, we were able to see that women exposed to 3 or more ACEs were significantly more likely to develop the diseases that you see here. And then finally, after determining the proportion of disease cases associated with ACEs, we wanted to determine the impacts, the cost impacts of those ACEs. So we used data from Access to approximate those annual costs. And this slide shows the estimated annual costs for women exposed to 3 or more ACEs and the listed diseases. So the lighter gray bar is the upper bounds estimate of costs, the darker gray bar is the lower bounds estimate, and that red bar is the average estimate of annual costs. So altogether, we were able to determine that exposure to 3 or more ACEs for women is associated with about $260 million annually in healthcare spending. That represents about 16% of the total Medicaid spending on women with these diseases in 2019. It's important to note that this only represents the amounts paid by Medicaid. It doesn't include copays, deductibles, private insurance costs, and it doesn't reflect other societal costs like lost work productivity or wages. So I hope you found this information interesting, and I would like to briefly thank our collaborators. Again, the Arizona Community Foundation for sponsoring this work, and we received research assistance from the College of Health Solutions, Dr. Eric Hedberg, Mackenzie Brooks, who's a Herberger Young Scholar, and Kelly Brown, who's a Flynn Scholar. So I'll turn it back to Kavita now. Thank you.
That is just fascinating, Erica. Thank you so much for walking us through the findings of the report and also doing the research along with your colleagues. It's pretty fascinating, and it's amazing that we have this report now available to us in Arizona. So we're going to go ahead and move on to our panelists. So panelists, if you have a minute here just to turn on your video so we can see you. I'll wait till I see everyone pop up. Great. Good afternoon. Go ahead and unmute if you are comfortable. We'll start with Dr. Rodriguez. So Dr. Rodriguez, you have worked many years with women, working specifically in women's health. And the report, as Erica had mentioned, specifically highlights the impact of ACEs on women's health. So I'd love it if you could share with us how you have seen adverse childhood experiences show up in your work working in women's health.
Sure, Kavita. Well, as a midwife serving Native women, I have seen the effects of ACEs. I am also aware of what drives the increasing rates of maternal health inequities. The recent publicity regarding health adversity in women of color has generated a lot of attention to implicit bias and the inequality of healthcare, both of which play a large role in the persistence of trauma, especially in light of ACEs. According to the CDC, women of color are 2 to 3 times more likely to experience poor maternal and infant outcomes. Native women who have been affected by ACEs, as well as historic and current day trauma, have higher rates of hypertension, diabetes, and even obstetrical hemorrhage, which is bleeding that occurs before, during, or after childbirth. Women are also at higher risk for reproductive and birth injustices, which can magnify the effects of ACEs. I have been witness to what is called obstetric violence over the years. This term defines a series of emotional and physical abuses that are performed regularly on women during labor and birth, especially seen in women of color. Some examples of these violations include women being ignored during their time of need, being yelled at, verbally abused, being physically abused, being threatened, and being devalued. One study looked at the effects of various types of trauma and noted that women are more traumatized by repeated abuse rather than by the intensity of the abuse. So if a woman was exposed to, for example, sexual abuse early in life, which is an ACE, and then she is traumatized during her birth experience and subsequently suffers from PTSD after the birth, the combined trauma produces a compounded situation called complex perinatal trauma. Perinatal refers to the time from pregnancy through birth and up to 1 year after birth. This web of trauma complexity can present real challenges in the planning and delivery of healthcare, let alone be a great burden on the nation's economy, especially if she develops chronic disease. Pregnancy and birth trauma can also provoke postpartum anxiety and depression, which in turn can negatively alter the level of cortisol, which is the body's stress hormone, thus reducing milk production and delaying breastfeeding success. The research has noted social and emotional dysregulation in children, which may be a consequence of maternal trauma as well. Finally, I'd like to bring light to just some other female populations that have potentially been affected by ACEs just by virtue of their race and/or ethnicity. This list includes, but is not limited to, victims of human and sex trafficking, victims of baby farms, missing and murdered Indigenous women and children, Native victims of man camps, women who abuse substances, survivors of female circumcision, victims of reproductive coercion as seen in the practice of eugenics, which includes the forced sterilization of Native women, the descendants of African slaves, Native American and Jewish Holocaust survivors, immigrants and refugees, and incarcerated women. Thank you.
Thank you, Luana. I really appreciate that in your response, you were talking about, you hit on quite a few elements, including, the devastating impacts of historical trauma, but just this concept that, when we think about ACEs, sometimes we just think about traumatic events that happen in childhood, but as we all know, traumatic events can happen throughout the lifespan and then it compounds, right? So thank you so much. I appreciate your insight. Sandi, now listen, a lot of your work centers around how we can best support parents and caregivers. That's something that I'm always so proud of knowing you for. So tell us, give us your expertise, share with us your insight. How can those who are listening support parents and caregivers? How can we make sense of the report findings, in terms of those that are supporting families? What's the significance for them?
Thanks, Kavita, and I appreciate working with you too always. So I think first and foremost, just repeating what Erica said, is ACEs are incredibly common, and I think we can't say that enough. I think most of the people working directly supporting parents probably have some idea to a pretty involved idea of ACEs and the impacts. Our information is growing. I'm excited to see what the next round of data collection brings for Arizona numbers so that we can expand that, as Erica said, be able to include some of those other groups. But I want to start out first by saying, when we think about, and you pose the question, insights for people that support parents. And probably when Kavita said that, many of you thought about social workers and case managers and family practice physicians. But the reality is that ACEs are not just a household problem. They are a public health issue and a systems problem. And whether or not you work directly with parents, you have people in your organizations and your companies who are parents, who are adults with ACEs, addressed and unaddressed. So when we think about how we support parents in light of the information that we've received, it does us well to take a step back and everybody take ownership of this. And so even though, and in light of, and speaking directly to the fact that the data supported just looking at the health cost for women. When we look at women, typically our primary caregivers, and very typically are the primary breadwinners or financial support in the household. And speaking to what Luana talked about with historical trauma, we're looking at women with ACEs, and again, either addressed or unaddressed, raising children, and they have higher health issues in some of the leading causes, particularly heart disease for women. I think we don't recognize that heart disease kills more women than breast cancer. So it is one of the leading causes of death in women, and that having one or no parents is an ACE. So we see that perpetuation in addition to what we are knowing and beginning to know, and increasing our knowledge about epigenetics. So the things that Luana was talking about prenatal and perinatal trauma. So all of these things come together, and I don't know, we all have to take a deep breath because it feels so big, but it's like that metaphor, that joke of how do you eat an elephant? And it's basically one bite at a time. And so looking at how do we support parents? How do we support the people in our organizations who are parents? And what the Center for the Study of Social Policy and the Children's Trust Fund Alliance came together and developed the Strengthening Families Protective Factor Framework. And as I said before, that's one of the things I train on, and I firmly believe it's not a program. It is and not giving us more to do, it's doing more with what we already do. So focusing in on, there are a lot of protective factors, but focusing in on things like parental resilience and building communities and gathering support for parents, growing social and emotional competence of children, knowledge of parenting and child development, all of those things that help support parents. They all sound really big, but they are built one step at a time, one day at a time, one small significant step. And so recently, through the work in Arizona, the Collective Impact for Child Safety and Wellbeing, Prevent Child Abuse. Some of you may be on the distribution list and have seen the report that they recently published regarding a project called Lean on Me AZ, Lean on Me Arizona. And that was a bunch of community conversations overlaying the protective factor framework, asking communities, how do we shift our mindset from a focus on surveillance to a focus of support? And so in the report, we see what the community says we need to do to support parents and families and making them strong. And some of the things that are included in that report are things like focusing on strengths-based, that shift that we talk about in trauma work, which is shifting from what's wrong with you to what happened to you. Trusting parents, trusting that they are the leaders in their families and communities, asking them what they need. Understanding how our ideas of parenting, which are based on a lot of different factors, including our cultural and ethnic beliefs, and that there's no one way to parent, that as long as kids are safe, healthy, and thriving, parenting along mainstream ideas is not necessary, is not the only way. So those are just some things that are pulled out in the report. I'm a big fan of checklists, and especially Excel spreadsheets, but there really is no one way. There are a lot of really good ways, focusing first on building parent strengths and resilience.
Great, thank you, Sandi. Your guidance to us to take a deep breath came at just the right time, at least for me. And I really appreciate the analogy of, well, I'm not going to try to repeat it because everyone knows my trouble with phrases, but the one about the elephant really stuck with me, right? Because it can feel overwhelming. And if anyone's like me, I want to go out and save the world, but you can't do it on your own. You can't go for big, lofty goals. Sometimes you have to be able to work on something that is manageable. So thank you. I appreciate your insight. Dr. Shapta, you are heading up a one-of-its-kind clinic at Phoenix Children's Hospital. Congratulations again. How does this report impact your work and the work of your clinic? What does it tell you?
Well, I'm elated that we have a research paper that addresses the cost of ACEs in Arizona. I think it's very important that we have that to understand what decisions we make and where we put effort. The analysis looks at women in Medicaid, and it is an astonishing amount. And while the data is very important, it goes without saying that we must continue to factor in, as Erica said, other demographics such as gender, insurance, judicial, lost work, and of course, on my side, it would be the loss of the full potential in our children, our future. The importance of this paper is immeasurable for the work we're doing at the Center for Resiliency and Wellbeing. It clearly demonstrates that if we don't acknowledge and address trauma and toxic stress costs to human capital, it will be devastating not only to the individuals, but to the success, strength, and resiliency of Arizona, as it ultimately will affect the children and what our future is. We've only captured a glimpse of what COVID has sprung upon us, over the last years, and inequities, families living on the margin, how stress response occurs on each and every one of us, right? Every one of us have had that where we felt lonely or we felt sad or we couldn't, figure out why we were feeling what we were. And we all suffer from the stress response. And I think in the medical community, I can say just being a pediatrician, is we're seeing what COVID is doing to our adolescents and, even our parents, as Sandi said, the parents suffer and they're a big part of what we do. So I think we're going to in the future see a lot more as well. And so this is actually very important in the sense of understanding that if we don't put some front knowledge in and care at the beginning, we're going to have some trouble later on. The Center for Resilience and Wellbeing, which is the ACE program at Phoenix Children's that I'm the medical director of, spent the first year developing a strong foundation. It started in 2019, and we have screened thousands of children with the Adverse Childhood Experience Screening, the original one. And we've actually treated over 400 children and teens with a unique model of care that we use. In the program, we use a integrated, which would be the medical and the mental health aspect of it, kind of what's today. But we also have a second model, which is the integrative, which is really treating the whole person, where we look at the biological, the psychological, the emotional aspect, and even the environment of the child to really look at wellness and health. And we find that that's been very important and impactful. We have a lot of metrics. But this year we had to, because of COVID and just kind of even the studies that we're finding, is making some frame shifts to focus more upstream. How do we throw a wider net to make a greater positive impact and a culture change with what we do as a program and what our strength is? We know that there will be more children and adults on Medicaid. And the idea and the friendship that we're looking at is that it's imperative that we change the mindset relative to our culture, our policies, our health, judicial, and even our education systems to be able to identify early. That's really important to identify, to prevent adverse childhood experiences where we can, and then to mitigate those who have been exposed. And then ultimately to not only treat our adults, but of course, in my mind, being a pediatrician is what our greatest commodity is for the future is the children of Arizona.
Thank you, Dr. Shepta. I appreciate that so much. And yes, thinking about this just through the framework of the impacts of COVID on children and families, just in terms of the amount of loss that they have experienced, families have experienced, and how we might not see the impacts of that until much later in their lifetime. That's a lot to wrap my brain around. Thank you for sharing your insight. Erica, question for you. So other states such as California, Alaska, and Tennessee that you have mentioned in the report indicated a much higher cost of ACEs. However, in Arizona, the cost was $260 million. So can you explain a little more to us about this? How should we look at the data here in Arizona as it compares to or doesn't compare to other states? Help us understand that.
Yeah, that's a great question. It's really important to understand this too. So one big thing, so I mentioned the smoking, that we didn't include smoking, and that is a big source that is a big driver of costs in some of those studies. But another important factor, so we looked at costs specific to Arizona, and we looked at actual costs from Medicaid, from access. So some of the other states, what they did, they looked at national averages for costs. And then in some cases, some of the costs that they pulled were, gathered 5 or 7 years prior to the report, to the analysis that they did. So all of our costs are strictly 2019 costs and, are documented in Medicaid, in the Medicaid system. Some other things that were different. So like I mentioned, they included smoking. In other cases, they included depression and other mental health issues, and we didn't include that either. So there's a lot of other things that ACEs have been associated with. And like I mentioned, we just included the leading causes of death in Arizona. So we didn't cast a wide net in terms of the diseases. And then another thing, so when we calculated the attributable risk, we used a really conservative method of doing that. So we calculated it 3 different ways, and you can read that in the methods of the paper, but we chose to go with the most conservative. And so I think a big takeaway is that, the costs are a lot higher than what the analysis is going to show, because we were so conservative. We really wanted to generate a baseline that people could say, oh, okay, so minimum, we can see that the costs are this. The other big difference between our analysis and the other states' analysis is that we were looking at ACEs, at 3 or more ACEs. So in Tennessee, for example, they calculated the cost of exposure to any ACE, even one ACE. And then in California, the 10.5 billion is again exposure to any ACE. So I think it was when they looked at 4 or more ACEs, it dropped down to 3 billion, I want to say. So it kind of depends on what you look at and how big the net is. But like I said, we were just very conservative in our estimates.
Yeah, that's really helpful to hear, Erica. It sounds like in order to really understand the data, we definitely can't compare one state to the other, because the research methodologies were different. So yeah, that's really helpful to hear. All right, so we're going to open up to questions. So if you haven't had a chance to put your question in the Q&A box, please feel free to drop a question in there. We may not have time to get to all of them, but we'll try our best. All right, here. So let's look at the first question here. So this is a question for Luana, for you, Dr. Rodriguez. So this person had noted that they have never heard of obstetric violence, and they find that very troubling, as do I. How do you support, or how can we support pregnant women finding safe obstetric care?
Well, this obstetric violence is unfortunately related to healthcare providers. Those are the perpetrators, so to speak. A lot of what you would have to do is just stop it when it's happening. And that could be uncomfortable. That could be uncomfortable. If you happen to be a person that's going into the hospital with a laboring woman and you want to support her, it's very difficult to just open up and say, hey, don't do that. And women, if they're in those positions and they're in pain, they're definitely not going to always say something to protect themselves, to act on their behalf. They're too busy with the pain itself of labor. So, but you have to nick it in the butt, so to speak, because when it happens, that's when you need to say something about it. Otherwise, it'll just continue. It'll just continue.
I think it's helpful to hear about. I don't think enough of our community knows that this is, 1, a term, and 2, that it exists. and 3, it's something to advocate against.
And unfortunately, Kavita, a lot of women don't realize that's an issue. They think that they know labor and birth hurts, and they just kind of go along with it.
Yeah, thank you. Thank you so much. Okay, a question here. This one is for Erica. There's a lot of pieces here, so I'm just going to pick out one of them. So did the research team look at any hospital discharge data to calculate the price of ACEs in our emergency rooms or emergency departments?
Yeah, great question. So we considered a lot of sources for costs, and we ultimately chose Medicaid because it was really easy to tie to specific diseases for the diseases that we chose. So we didn't use hospital discharge data. That is another method. You could use that method. But some of the reason for that was because hospitals charge different amounts depending on the different locations of the hospital. So there's different amounts for different services. And then there's also a charge amount and a reimbursed amount. So they charge something and then they get reimbursed at a different rate. So there's all these weird little things that happen behind the scenes with costs. And that's why we chose the Medicaid claims data. And we did actually choose the paid amounts because there's different amounts that you can use. But that is a really good question.
Great, thank you so much. Let's see. I had maybe a little bit of a larger question for you all, but when you took a look at the report, this question is for any of you. What surprised you in the analysis? What kind of made you go, huh, didn't think I was going to see that?
Well, I can start. I was actually really surprised that the model only generated results for women. And I think it was from my perspective as a researcher, given what I know about the data, that was a little disappointing to see we only were able to generate results for specifically women. And I'm really hoping that in the future, when we have more BRFSS data, we can have more people in those different categories, and then the model will be able to generate more. And I really do want to say also that I think it's important to note that just because you experience an ACE does not mean you will have a negative health outcome. There's a correlation, but it's not a causation. So I think that's important to throw out there.
Great, thank you, Erica. Anyone else?
I don't think I had any surprises. Actually, just a reiteration of what I think all of us know working in this area is that it's very costly. And again, it didn't look at all the things. And so we know, as Erica said, was very conservative. And, in children, we see even more of a difference because if we prevent adverse childhood experiences and we treat it early, we don't know what the outcome is. We can't show what a return on investment is. And so to put a number on that is very difficult, and that makes it very hard to change policies and to change even, the idea of what do we do when we don't know what we've prevented for the future. So I love that we can look forward to what the cost is in the woman, that if we don't take care of the children and the people that have already suffered from an adverse event, what the cost will be to Arizona.
Mm-hmm. Great, thank you, Amy. Sandi, here's a question for you. So although there might not be a one-size-fits-all approach to parenting, something that I know a little bit too intimately about, the protective factors illustrate that there are aspects of parenting that are universal to successful families. Where does the biggest gap exist in educating parents about these important principles that will drive successful families?
That is an excellent question. The first thing that pops into my mind is thinking just in terms in general of parent education in general. We do not normalize that. Parenting classes, parents, seeking help. For all of us, asking for help is difficult for a variety of reasons, but we don't normalize parent education. It's only seen for those people that are having trouble or who are required by courts or by some other aspect to go to a parenting class. So parenting classes and parenting education in general is often seen as punitive and something for just when things go wrong. So I think the biggest gap really is, I think about, what am I thinking of? Childbirth classes. I'm thinking of childbirth classes that if you are in a group of friends and you say, my husband and I are going, or my partner and I are going to a childbirth class, everybody goes, oh, that's great. If you were with that same group of people in that same environment and you say, my partner and I are going to a parenting class, that reaction is completely different. Mm-hmm. So I think normalizing parent education, that everybody needs help at some point in parenting. I'm with Kavita. I am in my current parenting developmental stage of parenting teenagers and one that's about to fly the coop. And that is totally different than parenting a 5-year-old. So every child going through a developmental stage has a parent or group of parents that are going through that parenting developmental stage right along with them. So I think normalizing that everybody needs help, I think it is very impactful to trust parents rather than going to them and saying, here is what you need to know. Asking the question, what is it that would help you best right now? What kind of support will help you best right now in this moment? And having those conversations. There was a question that scrolled by very quickly about what can communities do? And communities can do the same thing. Those are difficult conversations when you see a parent struggling because parenting is a very intensely personal journey. But being able to say, what can I do right now to help the most? And the answer might be get out of my face, but at least extending that opportunity. I hope that answered your question.
I think it did, Sandi. Thank you. Thank you. I have a couple of questions here about homelessness. So maybe Erica, this might be, it's kind of measuring the link. So any thoughts around being able to collaborate with a local nonprofit provider, perhaps a homeless family provider to do additional research to look at the correlation between ACEs and homelessness?
So we have not looked into that yet. We are doing a lot of work actually around housing coming up pretty soon here. The Arizona Community Foundation has generously funded us for that as well. We haven't looked specifically at ACEs though, and measuring those in the homeless population. I think it would be really interesting. I think in a lot of ways, the homeless fall through the cracks, fall through the healthcare cracks, and in ways that we can assess them and assess their health. But I think that's a really interesting thing, and no, we haven't really thought about that yet.
Okay, some future work there. That's
yeah, it's always nice to get research topics from others.
Yep. Mm-hmm. So a question to any of you all on the panel: how can we use this report and this data to advocate at the policy level? What policy changes might we be able to advocate for that this report and this data might help us with? Big question.
Well, I can say with regard to what I spoke on, I feel that there's a great need to mandate more trauma-informed policy within social, education, and health organizations, as in hospitals, community clinics, home visiting, foster care agencies, senior facilities, universities, and in tribal health. That's very important, I believe.
Thanks, Alana.
being a pediatrician and the medical director of the ACE program, I'm going to focus on children because if we can prevent it, then we, save a lot. The problem is getting policies there for a return on investment. Again, you never know what money you're saving, but ultimately we know that adult disease is a developmental disease disorder. Most chronic diseases that adults have to do with when they're childhood. And so if we can start trying to educate even policymakers, even, all the different community leaders, experts about adverse childhood experiences. And we haven't really spoken about what I think is really important is the positive childhood experiences. And ultimately, to me, that's actually the most important because you can't always prevent adversity. We're all going to go through it. But you can buffer and you can improve and you can strengthen kind of the wraparound of these children, right? You can build a stronger community. And so going in and educating the teachers who are around these children for, hours a day, their community, things like YMCA, Boys and Girls Club, any of the faith-based programs, even in our program, we're educating pediatricians, going to pediatric offices and educating them. What is an adverse childhood experience? And how does that really come across in symptoms in children as opposed to waiting until you see it as an adult? So I think any place that, any organization, any job that people are working in, just the idea of learning about adverse childhood experiences, learning about what resilience is and how do you build that. And ultimately, I go back to it again and again is how do you listen to the people around you and try to understand them and know, that ultimately things are going on maybe from experiences and just listening. I think people need this.
Thanks, Dr. Shapta. So here's one of our last questions as we come up on the end of the hour here. So as a school social worker working with teenagers that are first-time parents, this individual finds that many families are repeating negative parenting and communication, likely that they experienced when they were a child from their own parents. What can Arizona do to help first-time families?
Well, I wonder, Kavita, do you have thoughts as well? I think you're an expert too on this panel.
I think that must be so tough for a teenager to be a parent. I remember when I became a parent and I was not a teenager and it was so hard for me. I can only imagine doing that as a teenager. So I think some of the first pieces have to be around validating and empathizing with what teenagers are going through as they enter a phase in their life that they probably were not expecting or planning to be in. And being able to have conversations with them around what was their parenting, what was their experience like as a child? What are some of their best memories? I think for them, it's first this concept of awareness of what their experience was. And how does that then taint their view or impact their view of how they will be as a parent? What is their vision for how they will be a parent? And then what are some of the hardships of being a parent that are probably exacerbated when you are a teenager? And being able to talk through that conversation. I don't know about you, but when I was a teenager, I did not like being told what to do. I can't imagine that has changed very much over time. And so I think it really has to do with the approach that we take with teenagers in not telling them what to do, but really holding our hand through it and talking about the experiences and who do they want to be as a parent? What kind of parent do they want to be? And then starting from there in terms of partnering with them on how they can learn to put into reality what they aspire to be. That's what I would say. Anyone want to add to that?
I would love to add to that, Kavita, because you bring up such an important point that most parents, and it's one of the things that I stress when I talk with parents is what kind of parent do you want to be? And we often don't take a pause in our parenting journey to think, you know, what kind of parent do I want to be? What kind of values? I use the metaphor of packing a suitcase. Your child was leaving for the journey of life tomorrow. What's the one thing you would pack in your suitcase, in their suitcase? And then thinking about how you want to teach them that. I think it's also important to understand adolescent brain development because we are expecting teen parents, you know, like you said, walking with them. Their brains are still developing. They still need the co-regulation of important adults and important, stable, healthy adults in their lives to help them with their own development. At the same time, they're trying to understand the development of their infant and young children and co-regulate with their children. So understanding and having realistic expectations of teen parents and understanding the support that they need to be able to parent their children effectively. And, you know, again, they're still teenagers. So there is this barrier of being able to say, I don't want to do things the way my parents did. And that's hard for them to stand up for themselves and say that. So I think that's important.
Absolutely. So as far as kind of next steps, how do we utilize this report to communicate to perhaps our governor, state leaders, business leaders, legislation? What are our thoughts? Tricky one.
I would go back to that. You know, this is a very, very expansive topic and very large. And like I said at the beginning, I didn't know that a paper that I was reading on the patio of my house one day in medical, that would change my idea of how I even practice pediatrics. It encompasses just about every aspect of our life, our day-to-day and community. And so I think the biggest to me is the call to action is educate and educate and educate yourself of not only what adverse childhood experiences are, but how they present differently in people. And the idea that having, we know that there's a dose response relationship, but that doesn't mean that if somebody only has one ACE, that they're going to be fine. We may find that if you have an ACE score of 1, you don't have buffer factors. You don't have a parent that's supportive. You don't have a school a teacher that made an impact in your life. They can have even more signs and symptoms of problems than somebody who has an ACE score of 7, but has a lot of buffers in their life. And so it's educating and understanding that. And then the other would be to educate the people around you of what it is and show that to them. So I think that's the biggest part. And then, you know, asking around you for how we can make a difference, not only in adults' lives, but in children's lives.
So I think what I hope to see is I hope that this report gives people some numerical language to talk about ACEs with in terms of costs and money. So sometimes when you're talking with those that deal with budgets, it's a lot easier to put dollar amounts to things. So I hope that this can help facilitate people's discussions about how preventing ACEs or reducing the number of ACEs might save money and, you know, suffering later on in terms of healthcare.
Mm-hmm. Yeah, absolutely. I think being able to speak the same language is always helpful, right? Yeah.
I also
All right.
with Dr. Shaptor. It's important to educate. Always learn more. Knowledge is power. Further educate yourselves on the ACEs and the associated effects on health. There's a massive amount of information available via the internet and through the ACE Consortium. And it's important to share any and all of the information with family, friends, work associates. Get it out into the communities. Make learning about trauma and what to do about it the norm. It's important.
Thanks, Luana. All right. with just a couple minutes to spare here, I would like to wrap up this webinar and thank our panelists, Dr. Luana Rodriguez, Dr. Amy Shapta, Sandi Cimino, and Erica Quintana for sharing all of your expertise with us. I also want to thank our consortium project director, Angie Burleson, as well as Stephen Killar from ASU Morrison Institute for all of the behind the scenes support to make this webinar happen. I saw a couple of questions here just about a link to the recording. Yes, it was recorded and it will be made available to all registrants after the webinar is over. We hope that you enjoyed this webinar, and more importantly, we hope that this webinar has given all of us a moment to reflect on how this report impacts our collective understanding of ACEs in Arizona, as well as our work to support children and adults in our state. So thank you again for joining us, and have a great rest of your afternoon.